Okay. So afternoon, everybody. I'm Saqif Hossain. I'm an orthopedic consultant who is currently based in Oldham, and I'm mainly a hip and knee surgeon, knee mainly. And as you would know, that most of us who are teaching on this are actually graduates of UCH, and I graduated from UCH in 1989, and then have been in the UK since '91. So the topic we were meant to discuss was the management of open fractures, which I'm sure you guys over there do treat a lot of, and we do so as well here in the UK. So essentially, what is an open fracture? Open fracture was what used to be called a compound fracture in the past, but nowadays we don't use that term compound, and open is a better way of sort of expressing what it is. So essentially, it is essentially a communication of the fracture with the outside world. So there's soft tissue damage, the skin over there's a skin wound over the fracture, and the fracture hematoma essentially communicates with the wound. Usually as a result of high energy, but not always. And so the components are essentially there is a fracture of the bone. I know many orthopedic surgeons believe, non-orthopedic surgeons believe that orthopedic surgeons only see just the fracture, but no, it isn't that isn't the case. There is significant soft tissue damage. There is something's happened. No. There may or may not be neurovascular compromise, but most importantly is that there is contamination of the wound. Whether it is less or more, that's all that is determined. So if you look at historically, Pierre de Salt, who was actually a surgeon in the 18th century, I mean, he noted that if you have an open wound over a fracture, if you deepen the incision to explore the wound, removed any non-viable tissue, and allowed a path for drainage, that improved the outcome. And he coined the term debridement, which we all nowadays call debridement. And essentially he stated that the sooner you do the debridement, the less likely that infection will develop. And this same thing was taken over, and in the early 20th century, Trueta actually came up with what was called the principles and practice of war surgery. And essentially he put together the same thing, is that there has to be enlargement of the wound to permit adequate visualization, assessment of the injured tissue for viability, excision of all contaminants in there, and remove any non-viable tissue, and then subsequently stabilize the fracture and establish an appropriate drainage of the wound. Okay, so we continue to learn about how to treat these fractures, and then so in the Second World War, penicillin came about. So once penicillin came about, we found that actually if you gave penicillin to these patients with war wounds, with open fractures, they actually had good results, and hence the whole concept of giving antibiotics for open fractures. So why is it we're so worried about open fracture? I mean, essentially, there is escape of the hematoma, and we know that the hematoma contains a lot of good stuff that's going to help in healing of the fracture. It also impairs the vascularity of the soft tissues and the bone. The bone subsequently may become necrotic. There may be bone loss. You may have left a bit of the bone on the road somewhere. And of course, infection, our biggest enemy. So what are the mechanisms? Generally speaking, they can be either direct or indirect trauma. So direct trauma like road traffic accidents, firearms, fall from a height. And then indirect are when you have torsional injuries, you can actually have fall from a height and then twist the leg, okay? And then the extent of trauma directly relates to the amount of energy that causes it. You may recognize this picture, and that was Tiger Woods' car earlier in the year. So what's the epidemiology of open fractures? We know that you get about 3.4 per 100,000, and that's the figure quoted by EFORT, because they did a study to look at what the epidemiology of open fractures were.
Saqif,
yeah.
First of all, I thought your slides are not moving.
They're not?
No.
Oh dear. Okay.
I just thought we were introducing, then he said about Tiger Woods' car. We can't see that. All we have is an open slide.
Hang on, let me go back then.
I think I know what it is. Go to your, make your thing whole screen.
Make it whole screen.
Yes, that's your PowerPoint, because you've got your PowerPoint.
Yeah. So.
Yes, that one, yes.
Is that working?
Okay, yeah, that's working now.
Okay. So if I go up.
And everybody, it's been recorded, so you as normal, you have the recording of this. And this is, I started from the beginning today. We get the recording on site, and you get the slides as well.
So that's Tiger Woods' car, by the way. Okay, I do apologize, that didn't work. So that's the epidemiology. Essentially, we know about 3.4 per 100,000 population, at least in Europe, sustain an open fracture in a year. And so, and the average age of the injury is usually is about 43 years. It's seen in young males and elderly females, and young males, generally speaking, are the ones who are more involved in road traffic accidents and sports. The elderly females are the ones who tend to fall over more and therefore may sustain open fractures because of the fact, again, their skin is extremely thin. The most common causes are crush injury, fall from a height, and this was a paper that was published in the Journal of Bone and Joint Surgery that looked at the sites where you tend to have open fractures. Whenever we talk about open fractures, we all talk about open tibial fracture. But the funny thing is that the commonest place you tend to have an open fracture is actually your fingers. The distal phalanx is probably the commonest place you have an open fracture. In a situation where you trap the finger in a door, either a car or whatever, and you develop a subungual hematoma, which is bleeding under the nail, that actually is an open fracture. That's probably the commonest one. But the one that tends to make the headlines are, generally speaking, the tibial fracture, which is the second commonest fracture that is seen as an open fracture. And also, we know that in 30% of patients, 30% of open fractures occur in polytrauma patients. So we look at the classification. I think as soon as people talk about open fracture, they go and talk about the Gustillo-Anderson classification. I still remember seeing that in my Bailey and Love, which I read many, many years ago. And this is essentially Gustillo, who described this classification in 1976. He's an Italian surgeon who described this and he looked at I think about 1,600 open fractures and classified them. And the classification was based on the size of the wound, the amount of soft tissue injury, the presence or absence of neurovascular injury, and the degree of contamination. And what he found was that the higher the grade of the staging, the higher the contamination and the poorer the outcome. So essentially, he graded them as grade 1, 2, and 3. So this is a grade 1 injury. It's a clean wound. It's less than 1 centimeter. It's usually a simple pattern of fracture. There's minimal soft tissue injury. It's usually an inside-out injury. So in other words, the laceration is caused by a bony spike from the wound, from the bone inside. So these usually tend to do better. The grade 2 are the ones that have a laceration, which is 1 to 10 centimeters in length. There's usually moderate soft tissue damage, but there are no skin flaps or degloving. And the fracture pattern is more complex. and there's moderate contamination. And then there's the grade 3, which has A, B, and C, is that these are usually open segmental fractures. There's extensive soft tissue injury. There is a significant periosteal stripping. In other words, the periosteum has been taken off the bone, and therefore that reduces vascularity of the bone. And one other thing he did put down was that if the injury was greater than 8 hours prior to presentation, they're highly contaminated and usually comminuted. And there's an A, B, and C, and this depends on the association of the soft tissue injury and neurovascular injuries. So a grade 3A is that there is soft tissue injury, the wound is great, or the wound is greater than 10 centimeters. But when you actually look at the wound, you can actually get adequate skin cover. There is periosteal stripping in these patients. And in the grade 3B, you are unable to cover the wound with the skin. There is significant periosteal stripping. And so because of that fact, you have to almost certainly have some form of plastic surgical input. So soft tissue reconstruction is necessary. And in the grade 3C is when you have vascular injury. And this requires repair. Usually you will need reconstructive surgery. And the infection rate in these patients is up to 50%. This is an acute emergency where the vascular surgeons need to be called in ASAP. So this is just a summary of all of that. And what you can see is that in the grade 1, Gustilo-Anderson grade 1, the infection rate is usually less than 2%. In the grade 2 is between 2 and 7%. In the grade 3, it's from 7 to 50%. And in the grade 3C is where you have the highest rate of infection. So one thing that you need to be very clear about is that when you do your Gustilo-Anderson grading, it should not be done in casualty or when you first see the patient. It needs to be done after adequate debridement has been completed, because it is only then you would be able to see whether it's a grade 2 or a grade 3, for example, because a grade 2, you have the wound, but you do not know whether there is periosteal stripping or not until you've actually opened the wound. Secondly, is that the 3 centimeter wound that you see, when you do a debridement, you might actually find that the amount of skin you've got to take out, because it's non-viable, now makes it a 12 centimeter wound, in which case it's now a grade 3. So the grading should not be done in casualty, it should only be done after the adequate debridement has been completed. So following on that is the so-called mangled extremity severity score, which is MES, and it has multiple things in there because it's not just the wound as we see it. Essentially, we've got to look at the age of the patient, whether the patient's blood pressure was reduced at any point in time, or is it still persistent? What is the pulse doing? What is the limb ischemia? And this determines as to what the rate of amputation is going to be. And what we do know that if the score is more than 7, then you can actually predict an amputation with 100% accuracy. So this was published in 1990s, so it's quite an old paper. But going on from there, what we did do was there was the so-called Ganga Hospital score, which has put together the MES score and the Gustilo-Anderson score. And what they looked at was skin loss, soft tissue injury, bony injury, and additional risk factors. And what was added on were things like chronic illness in them, any systemic injury, other trauma. All of those tend to increase the risk of that patient. And so this chap, Dr. Rajasekharan, whom I have actually met some time ago, he and his team at the Ganga Hospital put all of those together and then came up with a scoring system. And what was seen that if the score was less than 14, that it shows there's a good specificity and sensitivity in predicting that salvage in open tibial fracture is possible. If the score is greater than 17, then it was shown that the efficacy of predicting that an amputation was necessary was very high. So this is something that is used worldwide nowadays to actually score them in most of our A&E departments, and in theaters, we actually have this on the wall. So because of the fact it's quite complicated, if you just go through that, there are multiple things in there. I don't think any of us will remember each one of these parameters to that effect. So essentially, we have it on the wall so that we can actually refer to it when we're in theater, and then make the final score at the end, and then decide what the next steps are. So what are the next steps? What's the aim of this in the management of open fractures? What you want to do is prevent infection, ensure that the fracture heals, and restore function of that limb and that patient. And that's what we're trying to achieve by managing these open fractures. So initial management would be in line with ATLS, which is airway, breathing, circulation. And I know, cervical stabilization was put in with airway. And so normally, I don't know what happens in your organization, but in our organization, the accident and emergency team will carry out the ABC. Orthopedic surgeons tend to come in at the secondary survey point. So in the past, we were part of a trauma team, but we're no longer part of the trauma team because we are usually brought in at secondary survey. So once the patient has had the airways, breathing, and circulation sorted out, if there's any active bleeding that is stopped, then you would come in to assess the open fracture that's there. So when you've seen him, you would want some imaging. Plain x-rays are the best thing you can have. X-rays of the joint above and the joint below. And again, just to clarify that, don't take a single view x-ray as Prince William is showing there. It may have very different connotation as to what is being said. We tend to get CT scans if there is an intra-articular element of the fracture. And obviously, if there is any suspicion of a vascular injury, we'll get a CT angiogram. So what are the principles? Okay, the principles that is us as orthopedic surgeons seeing the patient in casualty. We'll need to give some analgesia to the patient because it is quite painful. Stop any active bleeding, splint the fracture, give IV antibiotics within 1 hour of the injury. And that's been found to be very, very sensitive. Give tetanus prophylaxis, remove any gross contamination. We tend to take a photograph of the wound and then cover it with a saline soap gauze. And I'll come to us the rationale behind that, and obviously replace any fluid or blood that may have been lost. And that would be part of the ATLS protocol anyway. And then after that, you're going to do a wound debridement and then stabilize the fracture, which are usually done in theater and not in casualty. So all this follows what's called the BOAST guidelines, which is essentially the British Orthopedic Association guidelines, which were published in 2017, and they have been updated since, and follow a very simple way of managing it. And it's very much similar to what the ATLS did. You may know what the history of the ATLS was, that essentially we didn't have a method of assessing and treating a patient in a sequential manner. And what we found was that if you followed that pathway, you will get better outcomes. In the similarly, BOAST have published a lot of guidelines on different things, including open fractures, supracondylar fractures, and things like that. And so looking at analgesia, we tend to give opiates, okay? You may or may not give nerve blocks. Now, nerve blocks are controversial, very controversial as to whether you should give nerve blocks or not. If you can give an ephemeral nerve block, for example, that's okay. But generally speaking, we would not do a 3-nerve block because of the fact that in a patient who has polytrauma or has an open tibial fracture or something to that effect, there is still a risk of compartment syndrome. So we would not routinely give full nerve blocks. Splinting is probably one of the best way of giving analgesia, and you can use different splints. It doesn't really matter what you use as a splint. Any effective splint is fine. Or you can use a POP back slab. Don't give a full plaster. It should always be a back slab. And even if you use for splintage, in the field, if you have two pieces of stick that you put around the leg and strap it round, that's fine. But as long as it is splintered in some way. Antibiotics, we would use broad spectrum antibiotics. What you need to do is cover gram-positive, gram-negative, and anaerobes. Usually, most hospitals have local protocols based on what the common organisms that tend to show themselves up in our area. We tend to use a cephalosporin and metronidazole, and this must be given within 60 minutes of the injury. If we delay that, there certainly it has been shown that there is significant risk of increasing the rate of infection. I did an audit in our hospital over the last year or so to see what the level of giving these antibiotics within 1 hour has been. Unfortunately, you'll say that, oh, we're in the UK and so everything's going fine. It isn't. And what I have found in our hospital, which is a trauma center, we're only getting the antibiotics in within 60 minutes in about 60% of the time. And in 40%, we're delaying it for whatever reason it is. It isn't happening. So the education of our A&E department is continuing. Antibiotics need to be continued for at least 72 hours post-op. And certainly the Cochrane review showed that antibiotics for preventing infection in open fractures was extremely beneficial. But we knew that even at the time of the Second World War, as we said, when penicillin first came out, that if we gave them a shot of antibiotics, there was a significant reduction in the infection rate and subsequently amputation rates. Come on. So in the A&E, wound management, just take off the gross contamination. Don't do a washout in A&E. It doesn't work. There's a lot of evidence to show that, pouring lots of saline and filling the floor with it does not really work. Take a photograph of the wound, cover it with a sterile saline soaked gauze. The main thing about taking a photograph is that if, for example, you go and have a look at the wound and say, okay, this is a 7-centimeter wound, and then another person comes along. So let's say the consultant comes along and says, oh, I want to have a look at the wound. It means that you're having to take the dressing off to show the next person. And then the plastic surgeon comes along, and then the vascular surgeon comes along. So we don't want to do that. So for that reason, what we do is we take a photograph, keep that in the notes, so that the next person who comes along who needs to have a look at that wound simply looks at the photograph rather than taking everything off. There needs to be the relevant governance in the hospital for taking photographs. In today's world, you have to have consent, and the photographs need to be taken only for the purposes of the management of the patient. It should not go on social media and things like that. So there needs to be the adequate governance in place. So when do you do the wound debridement, the proper debridement of the wound? And again, the Bostow BAPRAS guidelines recommends that the wound debridement be done within 24 hours. What that is essentially saying that if a patient comes in at 8 o'clock at night, there is no need to go in at 2 o'clock in the morning to do a wound debridement, because the chances are that you wouldn't actually have adequate staffing or instrumentation to perform that. Secondly, that normally you would want to stabilize the wound, and you may actually have the ENT nurse on with you at night who is unable to get you all the kit to put your fixator or whatever you're going to be doing. So doing this in the middle of the night is not a good idea. And it has been shown that delaying your wound debridement for up to 24 hours does not have any significant implications, apart from, and I'll come to those reasons why you have to go to theatre early. As much as possible, it should be done as a combined orthopedic plastic surgery procedure, but not all hospitals have plastic surgeons on site. Certainly in the hospital I work in, we don't have a plastic surgeon on site. So that you should not delay taking the patient to theatre just because the plastic surgeon is going to come in 2 days' time. So you should go ahead and do it whatever. But if you have a plastic surgeon on with you, it makes life a lot easier. So why would you go into theatre immediately? If you're going in immediately, would be there's significant contamination of the wounds, for example, farmyard contamination or marine contamination, then those patients need to go to theatre early. If the patient develops any signs of compartment syndrome, then that patient needs to go to theatre early. And if there is any vascular injury, in other words, a grade 3C injury, then that patient needs to go to theatre with the vascular surgeons, obviously. And also in patients who have polytrauma, because you've got to stabilize them in line with something called damage control orthopedics. So you're going to take them to theatre, you need to take them early to stabilize them urgently. So the reason why I talked about, as to when you make a decision on your Gustilo-Anderson grading, you can see that in this patient, that is the wound that the patient came in with. Now, if you look at the wound in A, you may think that, oh, that's probably a 1, maybe a 2. When you now go in, you extend the incision and have a look inside, you now see that bits of bone are falling out, which means that there is significant periostal stripping. So that has now gone from a grade 1 or 2 to a grade 3, a 3A at least. So, which is why you've got to do your assessment of the wound and the fracture after you've completed your debridement. You've got to do aggressive debridement. It has to be thorough, and this is critical. Okay, you can use low or high pressure pulse lavage. Both are equally effective in reducing the bacterial load. You can irrigate with what you should do is irrigate with normal saline. There have been talk about putting antibiotics in the fluid, and that has not been of any benefit. Normal saline is good. Use 3 to 9 liters. And if you believe in the AO recommendation, AO actually says you should use 12 liters. We usually tend to use between 6 and 9 liters is what we tend to use. By that time, you're actually tired and bored of spraying water into a wound. But what we have seen is that as long as you use at least 6, probably 9 liters, it's adequate. And you just need to use normal saline. And essentially what you're aiming to do is dilute the bacterial load in there. While you're in there, all dead tissue needs to be removed. It doesn't matter what it is, you need to remove every bit of dead tissue. Any little dead tissue that's left behind would cause significant risk of an infection. Bony fragments without any soft tissue attachments, those need to be taken out. Like in this one, where you have this piece of bone, which obviously has not got any soft tissue attachment to it, you need to take it out because that is not going to survive. Some people used to think that, if you leave that in, it'll act as bone graft. That isn't true. It doesn't work. It's actually a nidus for infection. So once you've done your wound debridement, what you need to do is see, as much as possible, you want to try and cover the nerves, the vessels, the tendons, and the bone. But in so doing, you want to avoid any dead space. So cover it as much as possible, put some loose stitches on the skin flaps so that they're opposed. You can use local antibiotics. We have used something called Stimulan. Stimulan is essentially a calcium sulfate beads into which you can put antibiotics as you wish. And we tend to use usually gentamicin and vancomycin. You mix it all up and you can put it inside, and the Stimulan within 28 days will disappear completely. And it tends to leach out antibiotics into the local area and therefore reduce the rate of infection. And that's been used across both North America and Europe with very good results. You can use vac dressing, which is vacuum dressings. So these are the suction dressings so that you suck out any excess fluid in there. You can use biological dressings, and I'll show you a few of those. But the main thing is that once you've done the initial debridement, you have to repeat the washout again in 48 hours. Generally speaking, you will tend to leave the wounds open so that it drains out after the first debridement, and only look at closing the wound after the second debridement. So these are some of the biological dressings you can use. You can use this, what is called the semi-permeable films, there's Epigard, or you can use skin graft, which is if you have the plastic surgeons with you, then they can do the skin graft for you. I don't know whether in your case, whether the skin grafting is done by you guys or not. In the UK, certainly skin grafts are done by the plastic surgeons. We don't tend to do skin grafting. We're not very good at it. I've tried it a few times, but it didn't work in my hands. So in the second stage of management, you need to continue with the antibiotics, okay, based on microbiology advice. The soft tissue coverage will be determined by the condition of the wound, where it is, the size of the defect, the tissue availability, other reconstructive procedures, what the bone's doing, what the joint's doing, and what the rest of the soft tissues are doing. And you also have to take into account of, the age and health of the patient. If they have comorbidities, that has significant issues. So for example, if they're diabetic, which is not well controlled. Smoking is known to reduce bone healing as well as soft tissue healing. And if they already have vascular disease, such as peripheral vascular disease, that may have an implication. And of course, the expertise of the surgical team and the equipment available for them will determine what you do. So usually you do what's called a staged reconstruction. And this is of both the bone as well as the soft tissue. So you could put in the definitive fixation at time 0, at the time of your first initial fixation, debridement, or you can do a secondary bone procedure. So you can put an external fixator first and come back another day. Bone grafting is something you can or cannot do depending on what the requirements are. Bone grafting are usually done in intra-articular fractures. If there is a significant bone loss, you can actually do bone grafting. And if later on, you can do an exchange nailing or fixation if that is required. That is essentially what is there in the staged reconstruction. And then, of course, when you have big bone defects, there are multiple methods of doing this. You can do bone transport, use of Ilizarov frames and things like that. And in some cases, what you need to do is a joint reconstruction. Now, this can be either by reconstructing the joint, as in the fracture, you reduce the fracture and fix it, or you may actually require to do some form of salvage procedures, such as fusions, or ultimately a replacement. The soft tissues, again, you may have to do secondary soft tissue reconstruction, such as doing free flaps, rotational flaps, if required. And then you may need to do tendon and nerve transfers if required, if those are damaged. Those usually are done by our plastic surgeons again. So what's the initial fracture stabilization? So when you're in there for the first time, you can either do a temporary or a definitive fixation. So a temporary can be an external fixator you put on, and then after a few days, once you know that you know what the viability of the soft tissues are, you then decide as to what the next stage is going to be. Most of us would tend to do an external fixator with a combination. So you have an external fixator on, you put a plate on one bit of it, because you know you can close the skin on that bit, but the other part you can't. And essentially, this is all determined by the degree of contamination, the status of the wound and soft tissue. In other words, can you close the wound? And other associated injuries and treatment. So for example, if you have somebody who has got bilateral femoral shaft fractures and open tibial fracture, it is preferable not to put a nail down this because of the risk of fat embolism and things like that. So in that situation, what you would tend to do is put an external fixator anyway. Also, the experience of the surgeon and the surgical team and implant availability will determine what you would use. If you're good at doing fixation, then you may want to do that early. If, on the other hand, you say, actually, we need someone else to come in and do the proper fixation, then you could put an external fixator and then come back another day to fix the fracture itself. So external fixation, and that's usually done for soft tissue management. So if you have got severe comminution, extensive bone loss, there's a vascular injury, you can put an external fixator on temporarily so that the vascular surgeon has access to the vessels, the plastic surgeon has access to the soft tissue. And also, if you have a fracture dislocation of a joint, so for example, you have an open fracture dislocation of a knee, in that situation, you may put a spanning fixator, which goes from the femur to the tibia. You hold it out in place while the soft tissue settles down, and then you may have to go in and do a reconstruction to all the ligaments if required. And I've already talked about the use of external fixators in polytrauma, something called damage control orthopedics. So what's the goal of external fixation? You could use it as a definitive treatment. I mean, there are patients in whom the external fixator is the method, the definitive method of treatment. Some of you, unfortunately, in your case, you guys probably wouldn't remember it. People like me do remember it because of our age, as to when we used to stabilize, we used to fix wrist fractures using external fixators, and that was the definitive treatment. So that you can use an external fixator to treat this open fracture. Or, as we discussed already, you can use that as a temporary spanning fixator until the soft tissue is stabilized, and then use the definitive fixation. And or, as we said, if you have a situation where you do not have the expertise to do the proper fixation at that time, you put an external fixator on, and then at another time, do the definitive fixation. You can do intramedullary, so in the primary stabilization of the wound, you can do intramedullary fixation. So you've got an open tibial fracture, you can actually put a tibial nail down it. The literature does support it. However, and I'll tell you in a few minutes as to why I say however, we have seen that using an intramedullary device is better than using an external fixator. And the basis of that is the biomechanics, because the working length of a nail is better because it is a load sharing device rather than a load bearing device. And therefore, the chances of bone healing is better. The chances of reduction of the fracture is better if you use a nail compared to an external fixator. The timing is very important. You can actually do it primarily if that is an isolated fracture. However, as I said, if the patient has multiple injuries, you tend to avoid using an intramedullary device because of the risk of fat embolism. Plate fixation. This tends to be the workhorse of most of the time, what we do when we fix fractures nowadays in terms of open fractures, especially if this fracture is an intra-articular fracture or a metaphyseal fracture, in other words, around the joint. And of course, if you've got patients with ARDS or polytrauma, you would tend to use a plate. So the plates can be a standard plate, which is in other words, you've opened the wound and reduced the fracture and put a plate on it, such as a DCS plate, a DCP plate. Or you can use minimally invasive methods. There are the MIPO techniques where you make small incisions, slide the plate under the skin and then fix it. Nowadays, we tend to use more and more locked plates. So a plate where the screw is locked into the plate. And there are now specific periarticular plates that are available by implant companies that we tend to use. So what's the risk of infection? We know, as I said earlier on in a previous slide, was that grade 3 tends to have the highest risk of infection, and so that's what we need to be aware of. But that does not mean because a grade 1 has a lower risk of infection, you don't carry out a proper wound debridement. So decision on whether to use a definitive or decision on definitive fixation is going to be determined by your skin cover. If you can get skin cover initially at the first debridement or the second debridement, then you can go ahead and fix it with an internal fixation device, whether it's a plate or a nail. If, on the other hand, you're unable to get skin cover, then you need to use an external fixator. And if you use an external fixator, the principles of using an external fixator is that you want to be away from the area of injury, or they call the zone of injury. So there is the so-called near, far technique, where what you do is that you have a pin as close to the zone of injury as possible without actually damaging it, and the other pins are away from the zone of injury so that it forms the most stable construct. Because what you do want to do is that the construct is stable when you put it on. And then once and then what you've got to be careful about is where you put those pins. You should know where the perforators are in the leg, for example, because our plastic surgical colleagues may want to use those skin flaps based on those perforators. The second thing is that the fixation, they say the external fixator should be away from wherever our vascular surgeons are going to go in if the patient has had a vascular injury. If, on the other hand, you were able to get into theater with your plastic surgeons initially, and they were able to aid in covering the wound, so you've got good skin cover at time 0, then you could actually go ahead and do your definitive fixation without your nail or plate at that sitting. So rehabilitation, that's the next bit. So what you need to know is that you do have to rehabilitate the limb, rehabilitate the injury, rehabilitate the patient, and also rehabilitate the family, because a person who has significant injury is going to require a lot of support from not just himself, but also his family. And that's the same across the world, that we have to provide this sort of rehab. So what are the complications of open fractures? Early, of course, you have a multiple injured patient. They could have shock. They could have compartment syndrome. There was a time that some people believed that if you have an open fracture, you cannot have compartment syndrome. That is incorrect. We do see a number of people who develop compartment syndrome even though there is an open wound, because of the fact that the open wound is only over one compartment of the leg or the arm or whatever it is. The rest of the compartments are still closed. And if there is an increased pressure in those compartments, then there may well be compartment syndrome, which is an acute emergency. You can have crush syndrome, you can have infection and sepsis, DVTs and PEs, which you need to be careful about. And these can go on to give you acute renal failure. Late complications are the sequelae of infection, osteomyelitis. The fracture may not heal, and you can go into non-union, either delayed union or proper non-union. And in many of these patients, they develop CRPS type 2, which used to be called RSD. And essentially, we don't know why people get CRPS, but it does happen. And I don't have the figures, but I would say up to 10% of patients who have open fractures develop CRPS of some description. So what are the amputation rates after an open fracture? Overall, it's been shown in a Scandinavian study that there was a 3.6% of amputation in all open fractures. And the higher risks are seen in patients over the age of 70. Male patients seem to have a higher risk of amputation. Patients fixed with nails, they seem to have a higher risk of infection. Now, I would be guessing, and this is the description, this is the rationale given by a number of papers, that the reason why nail fixation tends to cause more or increased risk of amputation is because of the fact that when you ream the canal and put a nail down it, you are essentially spreading everything up and down the medullary canal. And therefore, if there is infection, which is communicating with the outside world, there is an increased risk of you developing an infection and subsequently an amputation. It is obviously commonest in patients who have got a vascular injury. It has been shown that up to 20% of patients who have a grade 3C fracture may actually end up requiring amputation. Now, the amputation can be early or late. You could do, you trying to stabilize the fracture, trying to prevent infection, but you fail. It could be 6 months, 6 weeks down the line, everything has failed, and therefore amputation is at that time life-saving, and so you may have to do it at that stage. So in summary, we use the Gustilo-Anderson classification, which is the most common classification that we tend to use. There are the ones I talked about, the Ganga hospital scoring systems and the MES scoring system, but the one that tends to be known by all of us is the Gustilo-Anderson, which is a simple way of assessing an open fracture. It is dependent on the wound size, the amount of soft tissue injury, the degree of contamination, and the presence or absence of neurovascular injury. Always take a photograph and cover the wound. Antibiotics and debridement are pertinent. You have to give that. It is essential, or else you tend to have significant problems. That was a whistle-stop tour of open fractures. I'm just trying to unshare.
Okay, thank you very much, Saqif. That's a wonderful lecture that even a chiropractologist like me enjoyed very much. That's wonderful. Now, there's been a few questions, which is in the chat group. I'll read them out for everybody. But before I do that, as I started earlier today, before Saqif started talking, can we, as the questions are going on now, can we all please connect onto the website? The feedback form is on, and can we start doing the feedback as we go along, so you don't have to remember? In about 10 minutes, I'll check, and if there's not enough people filled it, we'll take a 3-minute break so that you can have time. The feedback takes only about 2-3 minutes, so we can do that. So I'll go with the first question, which is
it starts from, what kind of joint reconstruction do you have in mind in setting up an open fracture? No, when I say joint reconstruction, so it's not joint replacement, but actually the fact that you've got to reduce the fracture and anatomically and fix the fracture so that the joint is reconstructed. Because if you have any gaps, if you have any defects in the joint, then that is going to produce arthritis in the future, post-traumatic arthritis. So it is essential that in any intra-articular fracture that the intra-articular aspect is reduced fully. And therefore, there are currently plenty of plates that we can use, which will help in reducing the fracture of the joint, fixing it properly and in a stable manner, and therefore it reduces the risk of arthritis. So that's what we're trying to do with that. I'm not suggesting that you should do a knee replacement on the patient, because if you do a knee replacement, there is a significant risk of infection, which was going to be a major problem. The next one was ARDS, acute respiratory distress syndrome. It is a severe soft tissue injury to the lungs, usually due to polytrauma. In fact, People like Funsho know more about it than I do, because they tend to deal with it more often. But it is quite a severe respiratory distress syndrome. It's very similar to what we used to learn in pediatrics when I was in UCH about the respiratory distress syndrome in children. But in adults, it is quite severe. The mortality is very high, and the treatment is usually supportive with oxygen and supporting the circulation. About IM nails, can they be used in all Gustilo-Anderson grades? What's your take on timing of ORIF? So IM nails, generally speaking, it can be used in all grades of IM nails, but you just need to be careful because of the fact that if you did do a nailing procedure, there is an increased risk of infection, more than in a plate. So generally speaking, if it's a mid-shaft fracture, we would tend to nail it. Grades 1 and 2, we're not really, the concern is not that much. We tend to nail all of those. If it is an extra articular fracture, in other words, a shaft fracture, in the grade 3, especially grade 3B and C, we are less likely to use a nail in those patients, simply because that the infection rates are significantly higher, and we tend to use more plates in those. Timing of ORIF in open fracture, we tend to do the ORIF at the first time we actually get them to theatre. As soon as we've done the wound debridement, if I can get wound closure, in other words, the skin will close, I would go ahead and plate that or nail that immediately. I do not like using external fixators as such. I would use external fixators sparingly, and usually it would be done on day 1. However, if the wound is such that I cannot close the wound, or the plastic surgeons aren't going to be around for another 2 days, in that situation, I would put an external fixator on, ask the plastic surgeon to come along, and they will come and operate with us. They will put their grafts, their flaps, or whatever they want to do. And once they've done that, I would go ahead and plate it at that time. We tend to try and do early fixation rather than late, even in open fractures. Is the 3B and C that we are most concerned about, because those are the ones where the chance of infection is much, much higher. And many a time in those ones, we may actually keep the external fixator on for up to 6 weeks and then go in and fix the fracture once the wounds have all settled down. But that's not very common. I must say, fortunately, 3C fractures aren't very common. A little more clarification about the near, far pin fixation. Right. That is a biomechanical thing. Let me I tell you what. What I'm just going to do is bring up the picture. Oop, what happened? Okay. I mean, if you look at it in this picture, the fracture is somewhere there. Yeah? Can you guys see the
Yes.
And the concept is that, let me just move this down. The concept is that this pin and this pin are closest to the fracture, but not in the zone of an injury. You then put this pin and this pin, which is as far away from the zone of injury as possible, and then put the external fixator bar attached to it. Thereby, the working length, in other words, the the distance from the furthest point to the nearest point to the fracture is long so that it becomes more stable. It is important that your external fixator is as stable as possible, because what you're expecting is that if this patient walks on this external fixator, he's able to do so. So that is the concept, is that the near is this pin and this pin are nearest to the fracture site, and this pin and this pin are furthest to the fracture site, thereby giving you that concept of the near, far. There are other ways of making your external fixator more, how would you put it, more stable. You can increase the number of bars on the external fixator. You can increase the number of pins on the external fixator. You can get the external fixator to be closer to the skin, and the closer you are to the skin, the more stable your external fixator is. And it's all the biomechanics of how the pin and the bone and the bars all work. There is actually, you could actually have a whole topic on biomechanics of external fixators. And the whole idea of doing that is that you want to reduce the amount of motion at the fracture site. Okay, we know that the more motion there is at the fracture site, the less chance of it healing. Something called the Perren's theory is essentially a paper that was published by a guy from Oxford several years ago. And what he showed was that you need to have a little bit of movement for a fracture to heal. And how much movement is the question he'd put forward. And he'd done some work on rabbit femurs and showed that you had to make it stiff enough to support the bone, but at the same time not too stiff that there is no movement at all. And so that's the balance you've got to use with an external fixator.
Saqif, can I just interrupt you for a very quick moment? I'm inherently retentive about feedbacks, and I've only had 5 of you do the feedback forms now, and about 32 of you online. So that's quite a lot of numbers. I'll just quickly hijack the screen here because somebody has written that they can't find the feedback forms, and I'll just show it, and then we'll continue. I don't really want to stop this for you to give the feedbacks, but I think it's important that we do that. And I'll just try and share the screen so that you can all see where we are. So if you go to, can you all see this? If you go to the Moodle website, you'll see under Principles of Management of Fracture. So you can see the last factor there is feedback for management of open fracture lecture. Click on it and you can feed your feedback. Please, can we do it as Mr. Hossain is talking? And let's get the numbers up. Thank you. Saqif, continue.
Yeah, let me get I've lost the...
Okay, you were, let me see. What kind of joint restructuring? You've done that.
So I am Nails, a little more clarity. About the percent of CRPS, is it irrespective of treatment method? It is. We do not know why people develop CRPS. Hence, it's called chronic regional pain syndrome. In the past, it used to be called RSD, reflex sympathetic dystrophy, because people thought that it was a reaction of the sympathetic system. We do not know why people develop CRPS at all. We have no knowledge, and we need some smart people to investigate this and find out why people have CRPS. But what we do know that CRPS is more common in the upper limb than in the lower limb. We don't know why. And there are a lot of studies that have looked at that. If you look for CRPS, the incidence is actually quite high, and it could be as high as 20%. It's just that we don't bother to look for it. You said, can we use running tap for irrigation of open fractures? I guess we could. I don't see any problem with that, because if you actually imagine, when you scrub to operate in theater, use a running tap to scrub. It is probably better for you to use sterile saline rather than tap water. But I guess if you don't have enough sterile saline available to you, then irrigation is possible. The other thing you can use is a brush, and we have used the scrubbing brushes that you use for scrubbing. Use that to actually scrub the ends of the bone, and we've done that quite regularly to get all the contaminants off. So that is absolutely fine, but it's probably better to use sterile saline. So the Gustilo-Anderson limitation, can we use the other types which address such limitations? Yes, you can, absolutely. The thing about the Gustilo-Anderson classification is that it is easy to understand. It is easy to memorize because it isn't very complicated, and it's easy to vocalize. Whereas the other ones, both the MES score and the Ganga Hospital score, are complicated. We do use it in our hospital, but unfortunately, none of us can actually remember the exact components of it. So what we have actually done is that we have put a poster in theater that we can look at and see what exactly is going, what are the components and where we are up to. And we have somebody who actually charts it to say, skin, bone, soft tissue, and all of that stuff. And then at the end of the operation, we are told what is the score. But the Gustilo-Anderson classification is one that is easy to understand, and we tend to be able to talk to each other using that language of the Gustilo-Anderson classification. I guess the MES score and the Ganga Hospital score would be something that tends to come out in exams, where multiple choice questions will tell you which of the following is, and you unfortunately will have to learn it for just that day when you're going to do the exam. You talk about Stimulan. It's actually called Stimulan. There isn't a T at the end. It's actually a company that makes it. And essentially, I will give you, I don't have the exact components of it. I use it quite a lot, actually, as do many vascular surgeons. And I'm just going to find out what is in it. So it's made by Biocomposites, and it contains, is essentially calcium in it. But the main thing about this stuff is the fact that the calcium gets absorbed into the body, and so there's nothing left behind. And especially in a patient who has an open fracture, the last thing you want is foreign body left inside there. So Stimulan is just one of the delivery methods. And I'm sure there are many, many other companies that make such stuff to deliver antibiotics into the local area. It's just that in the UK, we tend to use Stimulan. And that's for the feedback that Funsha has already shared. How early should we start thromboprophylaxis in open fracture? Thromboprophylaxis should be started immediately, and which essentially means within sort of 8 to 12 hours of injury, you should start thromboprophylaxis. Unless there is a reason why you wouldn't do that. Now, in terms of thromboprophylaxis, it doesn't have to be mechanical. It doesn't have to be chemical. It can be mechanical, which can be started immediately, because even as you have the patient on the table, you could have, TED stockings or compression devices on the other leg, squeezing it so that you prevent DVT forming. The evidence is suggesting that if we don't prevent DVT, certainly in the UK nowadays, the lawyers tend to take that into account and come after us. So we tend to start DVT prophylaxis very, very early. So what I would do is I tend to put them on a mechanical prophylaxis, within minutes, in other words, as they get to theater. And if I'm not taking them to theater that night, they will be given a shot of Clexane, which is our standard DVT prophylaxis in terms of chemical prophylaxis. Why using plates for femur fractures in ARDS? Is it to save time? No, it's not to save time. It's just that if you do a nail in a femoral shaft fracture in a patient who has ARDS, as soon as you put the guide wire down the medullary canal, you throw out emboli into the system, usually the fat emboli. And if you ream, you will get even more emboli going out. And if you have a person who already has had damage to the lungs, and you do throw more emboli into the system, the ARDS will get worse. And so in those situations, you should plate it rather than nail it. So we don't tend to nail in patients who are likely to develop ARDS or who have already developed ARDS. So if somebody has had multiple fractures, so as I said, bilateral femoral shaft fractures, as per the concept that is known as damage control orthopedics, you should not be putting a nail down in that patient. I do have a talk on damage control orthopedics. If anybody's interested, we can certainly go through that as well at some stage. Concerning the use of antibiotics, what is your take on the use of antibiotic beads? Well, absolutely. I mean, I use Stimulan. The problem with beads is that you've got to take the beads out. Because you do have gentamicin beads that are used, but the problem there is that you put the beads in, and because of the fact the beads then become a foreign body in that area, at a later date, you've got to go in and take those beads out. So for that reason, we tend to avoid that and use Stimulan instead, where we don't need to go back into to take it out. So that's one less operation for that poor soul. If orifice is done on day one, debridement repeated after 48, yes, absolutely. Because what we'll do is we'll plate it, but we will not close the skin completely. We will tack the skin together. We'll get them back 48 hours later, give it another debridement, and if everything looks clean at that stage is when we would close the wound. In our climate, we have a lot of socio, political, and economic disposing to a dismal outcome of our patient usually present late, sometime after visiting. What's the TBS?
Traditional bone setter, sir.
Oh, right, okay. Right, okay. Well, in that situation, you have already lost the game, the battle a bit, because of the fact that with the patient presenting late, the chances are infection has already set in, if that is an open fracture. I guess you've got to do the best you can and wash it out as soon as you can. In that situation, I would say that internal fixation at that point in time is probably not a good idea, because I think you've got to be sure that you don't have any infection in there before you start putting metalwork in there. So in that situation, I would say external fixator first, give that a couple of washouts to make sure it's all clean. Once you're sure that there's no evidence of infection, only then would you go ahead and fix it with the definitive plate or nail. That's what I would say, because one of the things that the MES score or the Ganga Hospital score put out is that if it is more than 8 hours after the injury, it automatically is taking it up to a much higher grade of injury. Antibiotic within or urgent wound debridement or skeletal stabilization can't be achieved on time. So what have we to improvise most times? Well, the idea is that neither can we. Now that's what I was pointing out, that I did an audit on our practice in our center, and we found that only about 50 to 60% of patients actually got their antibiotic within the hour. 40 to 50% didn't. We do know that has a detrimental effect on the outcome, but the thing would be to give the antibiotics as soon as possible. So if if the patient has presented late, there's very little you can do about that. You can't go back in time. So you've got to give the antibiotics at that time. But the main thing there is the choice of antibiotics, because you would know what organisms are rampant in your area that you've got to provide against, and what your sensitivities are likely to be. With the whole use of antibiotics in different parts of the world, there are many antibiotics which no longer work. There's a significant resistance, and there are problems with things, and then the issue of availability. I mean, if the antibiotic is not available, then there's not a lot you can do about it. So you've got to use what is locally available and what works for you locally. And your micro department would probably be best placed to advise as to what we should do. What's my opinion about early versus late wound closure? Well, you need to close the wound as soon as possible. Probably not on the first visit to theatre, but you do need to close the wound soon after. The earlier you can close the wound, the better the outcome. So what we tend to do is, if we have an open wound, we would wash it out, put some tacking sutures there, maybe some ethylene stitches just around to hold it, go back 48 hours later, wash it out again, and if at that stage everything looks good, I would do I would close it fully. But if you require plastic surgical intervention, then obviously that will need to come in at the time when they can actually put in the wound closure. But as soon as possible, you should try and close the wound. Avoid leaving wounds open for long periods of time, unless obviously if there is a lot of infection in there, in which case there's not a lot you've got to get rid of the infection before you close the wound, which is the old concept. You've got to allow the wound to drain out. We don't tend to use drains per se in open fractures. There was a time when drains were thought to be very helpful. I don't know what happens in general surgery, but certainly in orthopedic surgery, we have gone away from drains. We don't use drains at all. I can't remember the last time I used a drain, because of the fact that drains only drain the bit of tissue around the tube itself. It doesn't actually drain the cavity. So we would leave it open, essentially. For the sake of junior residents in orthopedic training, another method of managing bone defects is the induced membrane technique. I'm not aware of that. You will have to teach me what an induced membrane technique is. I'm not actually used that. I've not actually read about it. So here, what we tend to use is, if there's a bone defect, we can either shorten the leg, fix it in that position, or we could fix it with a bridging plate and put bone graft into the middle, or we could use an Ilizarov fixator, whereby we can either use bone transport, so we can either acutely shorten the leg and then essentially extend the bone with the Ilizarov frame. So I'm not sure what the Masquelet technique is. I will look it up. I'm not going to do it now. Masquelet. Antibiotic-coated iron nails are still not widely available in our setup. We don't have antibiotic-coated nails. We are aware of it. It turns out to be very, very expensive. The companies that make them, they tend to charge us an arm and a leg for an antibiotic-coated nail. So I have no experience of using antibiotic-coated nails, but in theory, I guess it will be good to use it. But the cost of an antibiotic-coated nail is about 4 times that of a standard nail. And so even though in our case, the patients don't pay for the implants, the government does, but the government are not very happy to pay for such expensive stuff. Debridement is usually not possible for up to 48 hours in our setting. would interim bedside irrigation have any benefit in the long run? I think it would. If you think that you're not going to get to theatre for 48 hours, then I think you've got to use whatever method of diluting your bacterial load as much as possible before you get to theatre. That would probably be okay, because our recommendation is that we get the patient into theatre within 24 hours. But if you're going to go to 48 hours, then I think you're better off doing something rather than nothing, I guess. If your patient can afford only one theatre session for a 3B, that's a difficult one. I don't know is the answer. I think, we've got to do the best we can, because the main risk here is loss of limb. So if you're going to go in once only, I guess you've got to wash it out. I would say in that situation, don't close the wound, let it heal by secondary intention, stabilize the fracture by some method. And in that situation, I would say an external fixator. Masquelade technique. Do you know, I'm not aware of this. Nobody's ever told me about that. Let me have a look again.
Emeka Elumelu, you had your hand up a minute ago. Do you want to ask a question?
Yes, sir. Good evening, sir. I think what I wanted to say about, I've addressed it in the chat.
Oh, in your chat.
Yes, I think the other area was talking about the Maslow technique.
Oh,
when you have bone loss. I think we have a patient who about 20 cm bone loss at the tibia, and the student just have to do something. So most people use the Maslow technique for such cases where you have induced membrane, you use the bone, and you come back later on, and you remove the bone and then come back. And it has worked several for.
I was just looking at what it was, what the Masquelade technique was, and it's essentially putting a temporary cement spacer followed by stage bone grafting, is what it's referred to. I must say I have no experience of doing that, putting cement spacer for bone grafting in terms of an open fracture. I mean, I do use cement spacers in infected joint replacements. So if I have an infected knee replacement, for example, I take the knee replacement out, put a cement spacer which has got antibiotic load in it, and then come back 6 weeks later and then put a definitive implant in. But I must say I've not used it in open fractures. Because generally speaking, in our case, we do have a very good limb reconstruction unit who would go in and put in a Lizarov frame if required. But I guess, I'm just looking at some of the data that they're showing. There are small numbers. There's this one done on 9 patients. So it goes back to 1986, and the numbers are small. This is a case report. So it's not something that we tend to use very often. I have to say, I don't have any experience of using bone cement as a temporary measure to fill a void. But I guess it could well work, but I couldn't tell you what the benefits of that would be.
Okay, any more questions? Okay, I think they're well educated with your with your lecture, Saqif. Thank you very much for this. And I think you probably still got 1 or 2 more moving forward.
Yeah, I have a few more.
Yeah, if I have a few more. Thank you very much, everybody. I would definitely have a better response to feedbacks today, because 19 of you I've already given.
The 30,
Yes.
isn't it? No, what 30?
Yes, there were 34. So,
Some have escaped.
yes, you haven't sent the feedback yet. So,
okay.
but I think that's a sizable number. But if you still want to, please go ahead. And I think that moving forward, I think with all these lectures, we'll give feedbacks as we go along once the question and answers come in, because we can make a meaningful decision about the feedbacks, and I'll forward them to Saqif later today. Thank you all very much. See you in about 4 weeks.
This is 4 weeks.
Yep. And also for the people on the audit and research group, I'll get in touch with you. I'm just trying to get permission from the powers that be in Ibadan, so I don't upset anybody. Oh, somebody's got a hand up. I'll just quickly ask one last question. Okay, Franklin Achumba.
Sorry, that was a mistake, ma'am.
Sorry, the hand was a mistake.
All right.
Okay.
Yes, ma'am.
Okay, that's okay. Thank you very much.
Thank you so much.
Have a great weekend.
Right, thanks a lot. Good luck, everyone. We'll see you in 4 weeks.
Good.
Thank you, sir.
You're welcome. Saqif, thank you.
Esheo.
Yeah, come. This stimulant, what's it like? What you put it in the wound?
Well, the stimulant actually is quite a good thing. I mean, we started using it probably about 3 or 4 years ago. So in the past, what used to happen is that if we had somebody who has an infection anywhere, especially bone infection, what we used to do in the past was to use gentamicin beads.
Yeah.
Now, the problem with gentamicin beads was the fact that we had to put it in on day 1, and a few weeks later, we have to go back in and take it out, which was 2 operations. There was some, we did have some calcium preparations where you could put antibiotics in and put in. But again, the problem with those were that the calcium sulfate or whatever it wasn't getting absorbed fully. So there was still some foreign body left in the soft tissues, which again was the focus of infection. So we were not too keen on it. And this time around, you couldn't take it out because there were little specules everywhere, and that's all you had. And Biocomposite, which is a company, is a German-based company that came up with this stuff, which is essentially purified calcium carbonate or sulfate, and it comes as a powder which you mix some fluid into, and it forms a paste. The paste can then be put into mats, so it forms essentially what it does is that it forms beads. And when you're mixing the powder with the fluid, you can mix whatever antibiotic you want, and they do have a recipe you can use for depending on what antibiotics you would like to use in those patients.
Okay.
And you put that into the mat, and then you can then put that everywhere. You can put it into the soft tissues, you can put that into the bone cavities, you can put it anywhere. And even inside the joint, we can put it in, because in the past, what was thought was that if you put it inside the joint, it's going to scrape the joint, it's going to destroy your joint. But it doesn't actually cause that either. So we use that quite often. So nowadays, in any infected joint revision that I'm doing, I use Stimuline in every single patient. And in fact, we're even thinking about whether the higher risk of infection in our case are in patients who are having a revision knee replacement, and whether we can use Stimulant with antibiotics in those patients. The company still does not have the license to do that, so we are not doing that yet. But certainly for infected cases, is fantastic. So we use it a lot. Our vascular surgical colleagues use it a lot.
Okay.
And then our diabetic foot group, they use it a lot. And they've actually found that the incidence of amputation for infection, especially in the vascular patients, have dropped significantly. They're able to salvage the legs. So even in your case, if you have a wound infection, for example, and you're going in, you can actually take a bit of, a 5 cc Stimulant, which is very little. You just put it under the skin before you close, and that, I think, will work quite well. there are some problems with stimulant, and you need to be aware of it. One is the fact that it can cause hypercalcemia.
Okay.
Two is that in a small number of patients, there has been some reports that the wound has oozed more than normal.
Okay.
It doesn't seem to cause any infection, but it just says that the wound oozes a bit more than normal. But the biggest problem that we have is hypercalcemia.
Okay.
So we have to be careful as to how much of the stuff we use, because I think there were people who used 40 or 80 cc's of the stuff,
Okay.
and were pretty happy with putting as much as. But what I've found is that if I use between 10 and 20 cc's at any one time, then it's fine. The hypercalcemia is not a problem. They don't have any significant hypercalcemia. But if patients already have pre-op hypercalcemia, we're just a bit worried about those patients.
Wonderful. I mean, that's great because I mean, for all I use really in dirty wounds is gentamicin. We've never had experience with beads at all in general surgery, which is only vascular. But I just use gentamicin, swab in gentamicin, literally, and liberates the wound with gentamicin. But obviously, that doesn't have a staying power.
Yeah, I agree. So the thing, because you're in, it's there in the beads, means that you actually have, it actually seeps out the antibiotics slowly over time, and it stays a lot longer than the beads, in fact.
Okay.
Up to 28 days, you would have antibiotics seeping out of that.
Oh.
Okay, so which is absolutely, and so you don't actually have to give them parenteral antibiotics anymore.
All right. Oh, good Lord.
So for example, if you look at it, in my case, when I do an infected revision knee replacement, in the past, what used to happen was that we would take the implants out, give them, wash it out, put a cement spacer in, and give them 6 weeks of IV antibiotics.
Whew.
But now what we do is we put it in, put Stimulan in, we give them usually a week of IV antibiotics, but carry on for another 5 weeks of oral. I guess as orthopedic surgeons, we are very worried about an infection. And in the second stage, what we used to do was, again, would put the second stage implant in, give 48 hours of IV antibiotics, and then give them another 6 weeks of oral. But now I've stopped doing that, and I tend to give them 48 hours of IVs and then stop.
Good Lord.
So there's significant reduction in antibiotic requirements. And in our place, we have community IV therapy and all of that stuff. There is significantly reduced need for those things. So we've had a lot of benefit from. So even though it isn't cheap, this stimulant stuff, it's about 150 quid a shot. But it saves us significant amount of money in terms of community IV therapy and giving them antibiotics and the cost of just the antibiotics themselves. We save quite a lot of money.
I saw that obviously I need to look into, because we do have a few of our patients that come in with, so I need to see how it would work in the peritoneum, who come in with generalized peritonitis. I've got one guy on the ward who's came in with perf D with a pH of 6 when he came in. We never thought he was going to survive, but he's still alive and he's going to go home. But people like that would benefit because they had gross contamination.
I will ask the rep. I'll send him a message now. I'll ask the rep whether it's licensed for use inside the abdomen.
Yes, I think that'll be something to look into.
Yeah, I'll ask him.
Okay.
Although he may actually cover you as well. I don't know. He's based in Leeds, but he covers the whole of Northern England. So
okay, yeah. So it would cover. It should cover us then.
Yeah, I'll find out from him and I'll text you.
Okay. Thank you very much, Saqif.
Right. Thanks, Marvin Shaw.
Okay. Thank you very much, everybody. Have a great weekend.